It's been a crazy few weeks in general practice, and as ever, we've got loads of information and news to help update you on what's going on. Whilst the blistering heat slaves on, we've got loads of stuff, including the changes in terms of the Prime Minister, changes in terms of hacks, in terms of the NHS IT, and potentially contracts being handed back as well. Let's take it hand to your primary care and learning. Hello, EGB learners, and welcome to this update episode that we've got for you, covering basically everything that's been happening in the past few weeks in general practice. Myself and Andy have taken a brief summer break, but we're back now, ready and raring to go, and loads of information to update you. Basically, what's been happening in general practice. But how are we doing there, Andy?
Yeah, good. It's quite hot over here. I've got a bit of sun cream on, so I'm probably a little bit more shiny than usual. But yeah, really keen to get talking about some of these issues. I've missed talking to you for the past few weeks, while we've taken a little bit of a break. But keen to get back down to it.
Absolutely. And we've got some awesome information to give you at the end of this podcast that's going to tell you basically all the stuff coming from EGP Learning. But let's get cracking with probably one of the key topics that's been going on and dominating the news cycles left, right, and centre, and that's the candidacy for our new Prime Minister, which is ongoing. Tell us about it, Andy.
Yeah, so I really enjoyed the episode we did about our new health secretary a few weeks ago. But there's an even bigger job up for grabs now, and that's the one of Prime Minister, narrowed down to two candidates, Rishi Sunak and Liz Truss. One of them will be the next Prime Minister. So I think it might be interesting just to talk about what's been said during their campaigns about health, what we think their positions are on the health service, and what either of them might mean for the NHS if and when they get the top job. So yeah, so a few ways to look at this really. The first thing I did, Gandhi, was go on their campaign websites and have a look at their key visions or statements and just see what they were saying about the NHS on there. So we can probably just open up Rishi's first. Ready for Rishi?
There we go.
So he does mention the NHS once in his 10-step plan for improving the country. And it's at number 3, cutting the NHS backlog. So that's been there, and that's been something that he's put out there at the beginning of his campaign. Think about Rishi Sunak. Sorry, the other candidate, Liz Truss. So Liz for leader, Truss dead to deliver. I did a search on her page at the moment, but on her vision site, looking for the word NHS, and it's not there, essentially. So she doesn't or didn't mention the NHS at the beginning of the campaign, which I think is really, really interesting. And then finally, I was having a look for a good summary article, as we often do in medicine, to see what's been said during the campaign. There's a good article from 3 days ago on the BBC that's just sort of highlighting what they've been saying, really. But anything jumped out at you, Gandhi, about how these two candidates have been handling the issue of the NHS health or social care before we dig into this?
I guess there's a bit of a stark difference in terms of the volume of content they're both putting out around the NHS. Normally, the NHS is one of the big political footballs whenever there's any form of election, and actually, it seems to be not as huge as normally would be expected. That's likely down to the cost of living crisis that we're experiencing, across the whole country, and obviously, finance is determining, I think, who's going to end up in the position of power. But as you can see from that comparison article, Sunak's got a lot more content around the NHS and stuff, whether it's valid content or not? Well, that'd be an interesting one. He's definitely been the most controversial in one of his statements, and that's the £10 charge for non-attendance, which I know we're going to delve a little bit deeper into. What were your thoughts on that particular one, Andy?
Yeah, well, let's get to the £10 in a minute, because there's probably a lot to unpick there, and it's not the first time something like this has been suggested or talked about. So it's interesting. So Rishi Sunak often talks about his background, and we hear a lot about his mum being a pharmacist, so having a role within the NHS. Talks about a little less, but apparently his dad was a GP as well, which is interesting. So that might actually say something about what he really thinks and what his real experiences of the NHS have been in the past, relative to what he feels he needs to say on the campaign trail. I think you're right. The main focus for this campaign has been around economic policy and the cost of living crisis. And I think actually Rishi Sunak I think he felt maybe he was not getting as much traction with that as Liz Truss, so tried to kind of pull us towards talking about the health service with some of these statements, particularly the £10. But it doesn't feel like it's really got that much traction, I guess. Just looking at the headlines here, so Liz Truss has said not a great deal, really. GP services need to be more accessible. Okay. Fine. It's quite vague, isn't it? There should be more mental health support available in schools.
Mhm.
Okay, that's a good thing as well, but very lacking on detail
Yep.
there. And wants to encourage doctors who came out of requirement to help during the pandemic to stay and come back into position. So if you're a retired GP out there, Liz Truss wants you to stay and carry on working. And I'm sure the rest of us, out here in the active workforce would really love that as
Mhm.
well, I guess. But is that practical?
Well, she
Any
picks
thoughts on
up on
those before we look at Rishi?
yeah, well, she picks up on 2 key points there. One is accessibility of general practice and stuff. Now, important to note that the number of appointments offered by general practice has significantly increased year on year and month on month, including as well. So actually, capacity is increasing every single month. The issue is that the demand is so significant that it just outstrips any form of capacity. And the third point she makes about, retaining GPs, well, absolutely, that needs to be the focus because we don't have a pipeline of general practitioners coming through that's going to help the NHS in a meaningful way in the next few years because it just isn't enough coming through. And actually, more and more people who are qualifying are just turning around and saying, actually, I can't take the amount of workload that's there, and they're cutting down. So actually, retention is the biggest issue in terms of fixing our current workforce crisis. And none of the priorities seem to be focusing on actual retention as such. It's more very arty-farty, woolly-woolly kind of things. Interestingly, NHS England did say that they are looking at quick wins to help with GP access. I would love to know what those quick wins are. I think almost every practice across the whole country has probably tried every quick win possible. So it's going to be interesting to see what that looks like. That was another article that came out, I think, just a couple of days ago, which the general view has been what on earth is a quick win in comparison to the current crisis we're dealing with, and a lot of it seems to focus around the Fuller report, which if you want to check out our episode that covers that, so we've covered that in detail. What about you, Andy? What did you think of those 3 points that Liz Truss made?
Yeah, so they're quite superficial, really, and there's a lot behind each of those to actually make it happen in terms of how's it going to be funded, who are the workforce that are going to do it, how's that going to be structured. So it's quite superficial. I think with both of the candidates, a lot of these statements appear quite sort of knee jerk and in response to current problems that we're currently experiencing, with a lack of really any focus on the underlying factors that have led us to the position we are at the moment in terms of the sort of chronic levels of underfunding, chronic underinvestment in workforce, training new nurses, GPs, and other healthcare professionals so that they can enter the workforce, dysfunctional workforce economy that we talk about a lot in terms of how people are incentivized to work without locum salaried GP partner and so forth. So they're not really getting to the crux of the issue, I think. But I'd just like let's go through Rishi's statements as well. I'm going to leave the
Sure.
£10 to last because we can really
Okay,
pick that one apart.
definitely.
But so promises to accelerate NHS targets to cut waiting lists, eliminating 1-year waiting times by September 2024. Set up a backlog tasks force modeled on the unit set up to roll out the COVID vaccine. Okay, and
Mhm.
that was something that the UK was quite successful in to cut bureaucracy and waste, drive reforms. We'll come back to the £10 charge. Offer diagnostic services, MRI, CT scans, closer to patients. In high street estate, for
Mhm.
example. Speed up approval of processes for clinical trials, creating single approval service for UK trials, and wants to expand the network of specialist surgical hubs that offer low complexity procedures. So I think we've seen these sort of knee and hip
Yep.
replacement factories in the past to get down waiting lists. And whilst I was actually somewhat critical of them in terms of taking low complexity cases and the tariff for that away from NHS-based services that are left doing higher complexity cases for
Mhm.
similar or tariffs that don't reflect the work. Actually, on reflection, those happened in a period of time when waiting lists were lower and were reducing. So
Mhm.
interesting proposals. A lot more detail with Rishi
Yep.
actually about how they're going to happen, if not how they're going to be funded, and actually probably just going through them again and potentially addressing some real problems actually in terms of increasing diagnostic scanning capacity. That's not a bad thing.
Mhm.
You can see the logic behind applying some of the principles of quick wins that we had during the COVID response to tackling the current issue of backlogs. And will that be funded to the same degree? I don't know, but
Mhm.
if it were, we might make some progress with it. So a lot more detail. What do you think, Gandhi? And you can lead us into the £10 if you like.
So I think the aspect of creating task force tax task forces and stuff to try and tackle the backlog. To be honest, almost every area across the country would have already done this. It's just whether or not there's going to be an additional funding resource to help support the work in order to deliver it and stuff. That'd be the interesting part, whether that's what he's promising. But you and I both know, with working within the system locally, that there's been task forces to look at this through ICPs and various other areas and stuff. I think the aspect of, surgical hubs, it can be potentially great for patients to have quicker access because they're able to churn through more of the low complexity kind of things. But actually, the patients are really struggling. Those more complex ones, they're the ones that are actually having the bigger impact on access and availability of appointments, because they're the ones that keep coming back because they are more complex and therefore harder to deal with. Um, and there is that aspect of, well, waiting for somebody who's low complex to become more complex and therefore tipping over. But then it's that added impact on the hospital services, complications, all that kind of stuff that comes through. So actually, what would be more ideal, is, in my view, is just increasing the availability of the surgical process itself. He's put some stuff out there. Let's be honest. He's put more content. He's put more substance behind his NHS plans compared to Liz Truss, and there is more seemingly reasoned kind of thought behind the processes and things in comparison to Liz's, which is just basically headline grabbing from my perspective.
A few of the statements. Sorry, again. I was going to say there's a few of the statements I've heard from Liz, just talking about reducing public sector worker pay outside of London and cuts to NHS management and so forth, which just make me a little bit more concerned about Liz as well. She's much more cut things, I think, than than Rishi, or is that way?
My general view is that, unfortunately, Liz Truss doesn't give a great deal of substance in comparison to Rishi. They're both crap at giving substance, let's be honest. That seems to be the political flavour, just to make a comment and no substance and things. But the comment that he did make that has definitely caused controversy is this whole £10 charge thing. And that has definitely riled many people in terms of their views and what that might mean for the future of the NHS and various different aspects. So for those of you who may not have heard about it, which if that's possible, I don't know, effectively there's a suggestion that he will bring in a £10 charge for patients who repeatedly do not attend appointments in general practice and potentially other areas and stuff. There is huge amount of complexity that comes with this. It is absolutely not covered in the detail. And that's where I think there's this element of it. Is this a way of providing a tariff for general practice potentially? Is this a way of how does the system even going to potentially work? How is it going to impact the patient doctor relationship when you start monetizing it more directly in the concept of a transaction? And actually, what would it even mean? I don't know. What were your thoughts, Andy? I know I've got Twitter threads and stuff around this personally, so happy to talk.
So this is one statement that got quite a lot of general attention, if or much more than the other statements that is made, and it reached the level where it's discussed in the coffee room at work. Yeah. So people were talking about it in the coffee room, and people, particularly the admin staff, were immediately saying, "Who's going to chase these people? Who's going to collect the payment?" We work in a deprived area. Would our patients be exempt from this anyway? So it would have no effect on their behavior. Those patients who don't perhaps earn enough to be deemed it necessary to pay this. But yeah, we were worried about who was going to actually chase these patients and collect it, and how would they feel if we were the people chasing them for money, and what would that do to our relationship with them? So people were actually not very impressed. And also, actually, if you start to think, how many DNAs did we have? How much money would that, how many repeated DNAs did we have? How much money would that actually raise? Would it actually be worth the effort of chasing? And it's not enormous sums of money.
Nationally, it looks like 2% of appointments are not attended by patients. There's also that aspect of what counts as a non-attendance. What about the patient who's actually admitted into hospital in the process of having their appointment? How can you put them down as a not attended? Because they may be unconscious in hospital, for example. That's one of the examples that we've had. I think there is an element of patients with chaos in their lives who forget or just don't value the appointment, so therefore it's lower down on the priorities, and therefore they're the ones that miss it. And those are the ones that sometimes do frustrate us, and it's potentially, and interestingly, the ones that frustrate us most as clinicians, or me at the very least, are the ones that actually we do want to see them, but they don't attend. And I don't think this will help fix that, to be honest, because often they don't attend because they don't want to come in, and we're trying to get them in, and actually then that's counterproductive. Because then they'll just say, well, don't book me an appointment in the first place, and I can't be bothered to come, and I don't want to come, and I don't want to see you. But you're right, it's that whole concept of what is the payoff if you don't pay? Who's going to do the payments, the processes? I'm sure they will end up bringing in a whole, well, it's up to your GP to decide if you get charged. And that is definitely something that none of the clinical staff want to be dealing with, because that is just a poison chalice that is just going to damage things, lead to complaints, lead to breakdown in patient relationships and stuff. And actually, it's in some ways, you and I have discussed charging in the NHS multiple times, and we're probably slightly more towards the fence than most of our colleagues and stuff in some ways. But this, in my view, is definitely not a great thing to do, to be honest.
Yeah, you make a really good point there, Gandhi, that actually a lot of the patients, a lot of the problems around DNAs is actually we really need to see this person, because if they don't control their diabetes better, they're going to have, they're going to need to be admitted to hospital. They might need amputations, or other interventions. And actually, we need to see them. And if we start attaching a fee to them having an interaction with us, they might just disengage even more. So it could potentially be quite counterproductive and actually raise costs to the system overall if we are not careful. The other interesting thing is that this will, for the first time, link having an appointment in the healthcare system with a payment system or mechanism or apparatus, a cost to the patient for the first time. And he said this would be a temporary measure while the backlog's there. But if this were to become permanent, it might open up the discussion of further charges around appointments. So there could be some creep, towards actually we will charge people for appointments.
And actually,
we'll put a charge on your credit card, and we'll not cash it. If you don't come, we'll cash the charge. You have to put a deposit on your appointment. Maybe that's the next step, and then people are paying for appointments. So there could be a bit of a slippery slope here.
Yeah, and why £10? If you're going to value it the actual cost of the appointment. So the PSSRU value the general practice appointment approximately £36 for a 10-minute consultation. Why is it £10 and not 36? If you actually wanted it to be evidence based and processed along what it should be, actually that's the value of the appointment. Because does £10 then mean that a GP appointment is worth £10? No, let's be clear, it is not worth £10. To the system, it is considerably more. Christina makes some excellent points, though. Who would keep the £10? Can you imagine the increase in abuse when we try to get the £10 from DNA patients? Yeah, that's definitely a concern for many people. And what sanctions if they don't pay? If they don't pay, if they have multiple DNAs, are we going to turn around and say, yeah, we're not going to see you? I can see how that's going to end up in the Daily Fail and various other articles and stuff into the media.
Yeah.
GP won't see patient because they can't afford to pay charges. That's not
got a prediction, Gandhi. I think even if Rishi Sunak wins, I think this will sink without a trace. It'll come in. He may feel obliged to do it. It'll be temporary. They'll probably say, "Oh, GPs administer it.
Yeah.
GPs are at the GP's discretion." Most practices won't do it, and then it'll be deemed not to be effective, and the temporary period will expire and it'll go. That's what I think will happen. But we will see.
We will.
And do comment. That was a great comment from Christina. I can see there are a number of people actually watching the feed at the moment. So if people have any opinions on these candidates, I'm sure people have lots of opinions, but ones that are suitable for sharing, then feel free to share them. We try not to get too political, but we have taken us there this morning. So so feel free to do that. But we do have some other stories to talk about.
Yep. And speaking of which, so Andy, have you noticed any problems in the past week or so?
So Adastra, people are probably familiar with getting Adastra printouts from NHS 111 services that notifies when patients have had contact with them and what happened during that contact, and if we need to take further action following that contact. So quite important communication. It's also important for the people working in 111 to have a system that is up and running and working so that they can run their operations and see patients effectively themselves. But there have been problems with Adastra and a number of other services. They've been subject to a ransomware cyber attack that have taken those systems effectively offline and for quite a long period of time. It looks like this problem first came to light on August the 4th when these issues began and are still running through to today, in fact. So yeah, Adastra runs 85% of NHS 111 services, apparently. So that's a lot of patients affected, a lot of interactions affected. And first reported a total system outage. So it was unusable, at least initially. Yeah, have you noticed any fallout from this, Gandhi?
So bizarrely, I've been on leave when this happened. You know, I commented that when it first happened, the day that it happened was my first day away from the practice. I was like, you know what? I go away from general practice for a day, and the whole IT system crashes. You know, my magical powers, unfortunately, are that valued by the NHS and stuff. But hey, but no, unfortunately, it is a much more significant issue that's been understood afterwards. So it looks like the parent company, Advanced, who holds all the different outlets that we talked about, including Adastra being one of its main ones, has been subject to a cyber hack, and as a result of that, it's significantly crippled the service in terms it can offer, and that information transfer has been a key part of this. And it, as you mentioned, Andy, it's still happening today. They are not back up and running. They hoped it would only be a day or two. It's now coming up to over a week. And this is having huge impact, particularly on NHS 111 and services of out of hours care across the whole country and stuff. They've had to figure out workarounds as a result of it, haven't they, Andy?
Yeah, so the backup plan is that the 111 services make a record of their interaction in Microsoft Word, and they email that to the GP practice, who can then choose to enter this into the clinical system in whatever way they feel is right. That's what the statement says. These are just some statements from Liverpool that Pulse was able to get access to. So I'm not quite sure how official these statements are, but that's the solution that's in operation there, I guess. And a very interesting statement here is, whilst this is not ideal, it is considered a lower risk to patient care than practices being unsighted on out-of-hours interactions, which was a really interesting statement. Looking at that as a layperson, you might think, oh, this is a low-risk thing that's happened. But it's just saying that actually it's lower risk to do this than to have no information at all, which is a bit sort of, well, yeah, that's pretty obvious, isn't it? It's still really quite a high-risk incident for this to happen. What's been really interesting is that this has not really been reported more widely at all,
No.
because I think this is a real significant patient safety issue. And also, how did this happen? It's only a few years since the larger scale, more widely reported NHS cyber attack a few years ago. How are we still this vulnerable? Then maybe good answers to that. It may be quite a sophisticated attack, but I think we ought to be asking more questions and more widely in the media. Yeah, they said hopefully things will be back up and running soon, but for the moment, we're receiving MS Word documents. Yeah. Any further thoughts on this one, Gandhi?
It's challenging, isn't it? So, nobody wants to be subject to a cyber hack, and the impact that we've seen when IT goes down is significant. And is there potential risk of harm? Absolutely, because information is not being able to flow. I've heard subjectively from many colleagues working in the out of hours service that they're experiencing a very calmer, I don't want to use the Q word, period at the moment, and they think that's just because unfortunately the information is not transferring through. So this is having a knock-on effect on general practice, who are then seeing a significant uptick in the number of contacts, and also they're also having contacts with patients where they've tried to make contact with NHS 111 services and they don't have that information to back up what those contacts were about. That's causing more concern issues and various other things. This is a great example where information transfer and the failure of it has a significant impact on the care that patients have, and why IT services are so valuable, but also the absolute importance of data security and stuff. And sometimes people minimize, oh, well, we're having to do this because of the IT governance and all that kind of stuff. This is the complexity, this is the challenge, this is the problem you get when it goes wrong and stuff. And we don't know, unfortunately, when Advanced are going to be able to get their systems back up and running to full capacity. And that's a concern, clearly. Yeah.
Yeah, absolutely. And I'm just wondering if anyone out there has been affected by this. We might have some people watching who do out of hours shifts, for example, and maybe can just give us a bit more information or an update of what the situation is at the moment. Another interesting element to this, and I don't know if there's any silver lining, I just thought it was interesting that there was a workaround, that was easily found, I guess. It's really, really simplistic, isn't it, to email Word documents? But even that could have been a lot more complicated. Since the NHS cyber attack last time, we've got widespread adoption of Office N365, this bespoke solution for the NHS provided by Microsoft, who are a world leader in internet products and security, which I think is a good thing. And actually, there's been a big push for everyone to move to the NHS email system, which is secure and suitable for transfer of patient data. So there was a fit for purpose sort of backup there, ready to be used. So we've got kind of multiple layers of redundancy within information transfer, which I think is actually a good thing. So if there's any positive then that is it to draw from this situation. But I'm sure there'll be further lessons learned.
Well, it puts a massive focus on business continuity plans for practices, for areas, for NHS 111 out of hours providers and that kind of stuff. Actually, have they reviewed their plans and stuff? What was I know when this happened, there was lots of concern that actually there was no plans. They were having to make a lot of this on the hoof because they hadn't bothered to, explore what this impact would have on their local area, particularly when the short, the outage went on for a longer period of time than a few hours and stuff. Because actually, that's when you start getting into real significant complexity and things in terms of what happens if the data doesn't flow and stuff. I think the NHS.net system is, it's the backup. It's not a great backup. There's still loads of potential elements of error that can happen, and risk and stuff, and absolutely puts into that spotlight of security and stuff. So, good sensible practice when it comes to using NHS IT, not sharing your passwords. Use a password manager, make your life easier. Something I talk about on a
Yep.
numerous basis and stuff, and things. And obviously, as you mentioned, the NHS.net N365 system is thought to be safe and secure and encrypted enough for patient data flows, but you should not be using any other kind of systems to do so because very few other systems are patient safe and stuff. So, if you are doing other systems, you need to be asking the question, am I doing this appropriately or not, and stuff.
Yeah, so interesting story, and I guess this time it looks like it was criminals with a financial motivation, but there are other bad actors out there, nation states. Won't name any, but it just highlights the vulnerability really of our systems, and not just health systems,
Absolutely.
but the rest of our infrastructure. It's in a similar situation. So yes, worrying times, but we had a backup,
Mm.
which is good. The next story covers probably the most talked about company on this YouTube channel, I think, over the years. A company that I find actually quite exciting, but also very
Mhm.
controversial at times. That's Babylon Health, and they've announced in the last few days that they've announced that they're withdrawing from some NHS contracts within the UK. Two contracts in particular.
Mhm.
One with Royal Wolverhampton NHS Trust, which was supposed to be a long 10-year partnership undertaken in 2020, which they're withdrawing from, and another agreement with University Birmingham, University Hospitals Birmingham NHS Trust. But I think the messaging there is that the contract termination might have come from the trust, or they've given notice on the contract rather than Babylon, which I think is interesting. Again, if
Mhm.
people out there are from Birmingham and have more information about this, it'd be really great to hear you comment. But let's dig in a little bit more, really. So,
Mhm.
the University Hospitals Birmingham contract. Do you know any more about the nature of that contract that's been ended there,
Uh,
Gandhi?
so a bit of a, standard. We don't know everything about this, and we're just commenting. We are by no means experts and stuff on it, but it seems like this was a contract that was designed to provide an automated AI triage system for the A&E department, kind of like a chatbot mechanism that Babylon have massively invested a lot of their resources into. And if you use the Babylon service, you may have had experience of using that through their GP at hand or Babylon GP services and stuff. But it was an extension of that to be used in the more acute setting of A&E departments to try and help reduce demand and stuff. So it looks like that's what the contract was about for that particular one, from our understanding of reading the details and stuff. The value of the contract, all the other kind of aspects, was it unclear at this point, and we don't know why it was returned. Although, as Andy mentioned, it does seem like it's more the trust themselves returning the contract back to Babylon rather than Babylon themselves pulling out of that particular one. The Wolverhampton one is a little bit more different, isn't it?
Yeah. So again, we're just sort of researching this from a distance, so we're not experts in these contracts, and we're largely just sort of looking at statements on the organisations involved, websites, and
Mm.
press releases and so forth. But in Wolverhampton, this looks like it was a partnership to provide something called Babylon 360 service to several 100,000 people, within that area. Just looking into what Babylon 360 service is, it's something which in Nottingham, a similar contract I think was awarded for a service called PKB, Patient Knows Best, and it looks to be a sort of ICS level type interface, which allows patients to message their GP or their hospital care teams, allows patients sort of visibility of the flow of information about them and access to their patient record, and insights provided potentially from that access, and to have some involvement and visibility of the referrals process. So it looks to be sort of the glue that's going to begin to hold some of these integrated care systems together. That's what the product that is quoted in the press releases, appears to function as far as I can see. But they've pulled out of that. So I think two interesting aspects to them pulling out, really. So one is their stated reason. So the company's stated reason for pulling out is the funding and contract environment of the NHS. And they feel that that's a difficult place to operate at the moment. So I think they're essentially saying that there isn't sufficient money within these contracts to operate them effectively. So that's an interesting statement coming from the company, and we can maybe talk about that a little bit more in a second, because I think that's interesting. The other thing is, I think it maybe says something about the promise of AI and some of the hype around that, and some of the expectations around what AI might have been able to do for healthcare systems in terms of doing things more cheaply and doing more with less, and that maybe AI is not yet, and I use the word yet because it may do in the future, delivering on those promises and allowing people to operate those contracts, with the necessary, efficiencies that maybe they expected, both on the commissioner side and on the people running the contract. So maybe it says something about the state of AI as well, and the expectations around it. Any thoughts yourself, Gandhi?
I think this may be multifactorial. So obviously pre-COVID, Babylon in particular, one of the companies focusing very much on remote access, and the ability for patients, no matter where they were, to engage with a health service, particularly GPs. So you could pay for their private service, which I think at that point was £25 a month or something like that, and you could access a GP remotely at your convenience, normally within a few hours, even if you wanted to and stuff. Obviously, COVID massively changed everything in general practice to increase the availability of remote GP access in particular, and almost every practice across the whole country went digital, and offering the same type of service in some ways as Babylon was currently pushing forward with. And therefore, I wonder if that massively impacted how their business model worked, because actually their USP had kind of gone overnight. And obviously, patients now can have engagement with their local practice through a remote interface that more. I mean, the term is often used, the working well. There's patients that are, generally more available and wanting convenience of time rather than necessarily continuity, had that increased availability because of telephone consultation in particular, and aspects of videos and online consultations from there on as well. So I wonder how much that actually had a knock-on effect in these remote companies and stuff. So in particular, Babylon, Livy, Push Doctor, those kind of ones. They all saw a massive reduction in use over COVID because of the fact that all practices were now offering it. That had an impact on the bottom line, from what we can see from Babylon. In particular, their investors seem to have, been less confident in their abilities to turn things around. There have been comments in, some of the financial papers about, lower investment VC funding and that kind of stuff coming through for Babylon, and then as a result of that, that's again impacting their bottom line. And they've often commented that they've used that additional funding to prop up the service rather than the GP contract itself, because as they probably found out, the funding offered by NHS England and the government doesn't actually meet the needs of providing a complete service to the patient population, which is what often many GPs have been commenting and practices have been commenting around, that actually it's massively underfunded and resourced to provide the care that is being asked of it. And it seems like Babylon have kind of understood that now, and they are now withdrawing some of their contracts. Now, interestingly, they haven't withdrawn their GP at hand service yet. And I think that's the part that many people are potentially looking at what happens next with Babylon, because they have commented that GP services in particular are as profitable to them as they originally thought.
Yeah, they're sticking with.
Yeah. So what does that mean for GP at hand is, I think, the bigger question that comes from this.
Yeah, they said they're sticking with GP at hand at the moment. They're committing for caring for those 115,000 patients that are registered with them in and around London, but they're not looking to expand their UK NHS operations currently. You alluded to the sort of financial position of the company Babylon. So apparently they're looking at sort of $400 million loss in 2021. There's been some interesting things happening with interest rates in the United States and globally, which means the cost of borrowing money to fund expansion is much higher now, which is affecting them as well. And they may have been making some staff redundant and so forth. So they're obviously tightening their belt a little bit, as many of us will have to do in the years going forwards. The other interesting thing here is it's just interesting how private companies can walk away from these contracts as
Yep.
well. Where it's an NHS trust or an NHS body, they tend to um, be more inclined to stay and stick with a contract that is difficult to deliver. So it's just interesting, and maybe says something about the risks going forwards of increasing reliance on private companies in healthcare. That they can and will walk away when things become unprofitable, because they need to protect their shareholders from the loss and keep themselves going as organizations. So I think that that's interesting. But yeah, really interesting story. Really interested to see how that develops. And it's a company I'm really interested in following because, as I say, I find them actually both exciting, but also a little bit controversial at times, and push the envelope. And but sometimes that's how change happens. So I don't necessarily hold it against them. The final thing is that sometimes I think, in some ways, the GP hand savers in Babylon, see, they may have been something that looks like an AI company or pretends. Not pretend, I'm being a bit mean here, but there's a lot of focus on AI. But really, I think that they were a video consultation company, which is a much lower technology. Actually, there's people, trained GPs, making the decisions and actually running the service under that. And as other people came in and become part of that business, as you say, the unique selling point goes away, and actually the AI stuff is probably not mature enough to do the heavy lifting yet, and deliver what everyone wants from it. And I think that maybe that's been revealed.
And it's interesting you talk about people walking away from things. So that leads us into our fourth story, about a GP practice in, I believe it's the Lake District, who unfortunately have had to walk away from their contract because of various funding aspects. Yeah, you could almost akin it to some ways what the Babylon system has happened, but it's slightly different. So this is a GP practice, the Lakes practice, I believe is the name, and they own a couple of practices based around the Lake District and stuff, and they've had to hand back their contract to the ICP because they are no longer able to provide those services because of a significant shortfall of funding based around temporary residence aspects. So for those that don't quite understand what this means, obviously, if you were to go to another part of the country and register with the practice temporarily, because, for example, you're on holiday, which Lake District is, a fairly good holiday destination within the UK, the practice used to get a small amount of money to cover the costs of the registration and providing that care for a short period of time. About a year or two ago, that got changed within the GP contract, so that wasn't just included in the global sum. So, they said that they increased the funding to allow for this. Clearly, haven't done. And as a result of that, this practice had to find alternative funding arrangements to try and support that. They did that through the CCG at that time. They had a different service, so it sounds like it was an APMS contract for those that know what those are. But an additional service they were offering, so therefore they paid an extra amount. But it seems the local ICB, because the CCG is now changed to ICBs, have decided to go with somebody else to provide that additional, transient population service. That's had a negative impact on the practice's finances, and they feel they can no longer continue providing care on that basis, and have done what is the nuclear option for many GPs, which is handing back the contract. That is interesting, to say the least, because I don't think this is going to be the first story we see of this ilk in the next year or so. But what are you thinking, Andy?
Yeah, no, I just think about, I immediately think about Skegness. That's the local area where a lot of my patients
Yep.
go, spend some time in the summer in their, holiday sort of caravans or holiday homes, or just on holiday there. But often it is for long enough, and they have, sufficient medical conditions and, need to be seen, that they will register temporarily with a GP out there. And
Mhm.
I can see it causing problems for that practice as well.
Mhm.
Again, I guess the reflection here is that we don't know the ins and outs of
No.
this. We don't know how on the brink, that practice was, before this. Some of these things often are the last nail in the coffin for
Mhm.
organizations. But there's a lot of practices struggling on the brink there, and there's a lot of
Yep.
practices with a lot of transient populations. So, as you say, this may not be the first that we see of this, and it's quite destabilizing, isn't it? If you're one of the
Yep.
people that live in the Lake District and that's your practice, this is really, really disruptive for you, for that practice to close down or need to move under new management, because of this issue, which really is sort of nothing to do with you, really, because you're not
Yep.
a transient patient. You're just
Yep.
somebody who wants to see their GP.
Yep.
So very sad, I think.
Yeah, I think it's gonna be interesting because we are talking an area of the country which is generally quite rural. As you mentioned, the density and, urbanization of those areas is gonna be quite low. So therefore, as a result of that, the practice will cover significant geographical areas, and that practice shutting now means that there has to be another provider found. The impact that's gonna have on local other practices currently continuing is gonna be considerably significant. I mean, you and I work in very urban inner city areas, and the density of practices is quite high as a result of that because the density of patients is really high. But if one of those practices was suddenly to shut down, whoa, that is a huge impact that's going to have on us. But in these situations, I really do feel sorry for those other practices as well. And let's be honest, it looks like this is a really well run practice from the information we're able to find out. So, and this is a decision that's been taken out of their hands. That £70,000 funding is not a small amount to lose. That is a significant amount of money there for many practices to handle. So, therefore, you know, taking that nuclear option and handing back the contract is definitely challenging one to make, but not one I would imagine that they would have taken lightly and stuff. So it raises the question of the continuation of services for that local area.
Mm.
How much responsibility the ICB has with this and stuff is unclear. Obviously, we're just commenting based on the information we've got, but it's going to be, unfortunately, I think it's going to be the first of many, if I'm being honest. You know,
Yeah, let's watch this space.
yeah.
And again,
Like
if
over
anybody has any
Cornwall,
comment,
like you said, Skegness, other kind of places and stuff, there's many kind of areas where this is gonna be quite significant in terms of the impact of, transient populations, temporary residents and stuff, and the impact that has on practices and things.
yeah. So if anybody's a bit closer to this than we are, then feel free to comment either now or offline, in the comments or Twitter, and the other ways that you can contact us, of
Mhm,
course. Um, Yeah, so I guess that's the last story that we had teed up to talk about this
mhm.
morning. But there are some things coming from EGP Learning itself. We've been away, but we've not stopped working to try and bring you interesting things to help take enhance your primary care and learning. Shall we talk through some of the things that are coming up later in the year, Gandhi?
Yes. So, both Andy and I have been working on a couple of projects, and in particular, one of the ones we're really happy to bring you this year is going to be our System One Facebook User Group Conference. So normally we'd run this early summer. It's been a little bit delayed this year because of a variety of reasons, but it is coming, and it's going to be the 11th of October. You can join us. You can join TPP, giving the headline talk about what's coming from System One, as well as various other providers, including our gold sponsors, Ardens and Primary Care IT, who are going to be unveiling all the stuff they've got to help practices and their populations. We're hoping to have some fairly cool talks for you as well, in addition. So we're just working on confirming those kind of names and stuff that you'll be able to hear from. But yeah, hopefully many of you've seen and experienced our conference offerings and stuff, and in particular, the System One Facebook User Conference is one that we really enjoy providing because it's just a great opportunity to learn loads and stuff about how to use System One more effectively in primary care. And if you want to sign up, go ahead and do so. So it's bit.ly/S1FBUG Facebook User Group 22, all in capitals and stuff. It'll take you through to that page, and there are some early bird tickets, which when they're gone, as ever, they are gone, so sign up quickly before they are, because there aren't that many of them this time round. As ever, if you do sign up, you get access to the recordings, and it's important you do sign up because we won't be providing the recordings after the event. So if you haven't signed up, you won't get access to the recordings. That is one change Andy and I have made over the past couple of conferences we've done because it massively changes things for us. But yeah, you just need to register and you'll get them, even if you can't attend on the day and stuff. So that is definitely a fun thing to do, as well as all the other fun stuff we stick into the conferences, like the networking, the competitions, and all that kind of stuff as ever.
Yeah, if
Thoughts
you've
on
not
that
been
one,
to
man?
I was gonna say, if you've not been to one of the EGP Learning conferences before, the platform we use, Hopin, is really, really great. Recreates some of the feel of a face-to-face conference. You can network and sort of chat roulette with other people who are attending the
Mhm.
conference and make interesting connections. Sometimes some of the speakers are in there as well. There's all sorts of features and functions that try and make it a much more interactive experience than just watching something on Zoom, which is certainly not what this is.
Yeah.
So yeah, save the date, 11th of October. In fact, don't just save the date, register and get it firmly in your diary. And then there's another conference coming up. So I'm not a GP trainer myself. Gandhi is, but I
Mhm.
always love helping to organize and deliver this conference, which runs a few times a year to really connect with the GP trainer
Mhm.
community and give them a space to educate one another, talk, meet and have some really, really interesting speakers on topics that you don't get at the other conferences. So it's been really, really fantastic and an honor to be involved in the past, but you've probably got much more to say about it, Gandhi.
Yes, this is our fourth version of GP5T. So, training trainers to train trainees, hence the GP5Ts and stuff. And we've got unique content. This is stuff that you won't see in any other type of conference environment, very much for GP trainers. So, we are talking a much smaller population out there of people to attract, but actually, it's been great. We've had up to, I think the highest we've ever had was about 80 people online at the same time to look about general practice training, hearing from some of our amazing speakers. And we've had some awesome speakers in the past. We've got some great ones lined up for you coming forward, including stuff around, the exams. That's always a hot topic, but also how to tackle other areas like differential attainment, how to look after yourself. That's one of the themes for this particular conference and stuff. In terms of looking after the value of yourself, and you know what. We love producing it. It is a Saturday because we find that's the best time for most of the GP trainers want to attend. And again, if you can't attend, don't worry. Just register. You'll get access to the recordings. Again, there are early bird tickets which are going to go really quickly.
Mm.
So please register soon. Otherwise, you will miss that cheaper cost and stuff. And yeah, share it as
Yeah.
well, 'cause this is something that you will definitely enjoy. The feedback we've had from both of the conferences every single year is unbelievable. And we love producing these kind of things for everybody out there. So do have a look at it, do register, and do share as well, because these conferences are, from our perspective, we think they're great because we put loads of time and effort into producing them for you, and we love doing it, and which is why we continue to do so. But yeah, let us know what you think, and if there's stuff that's missing, let me know. We might be able to
Yeah.
still add it.
Yeah.
We are still creating a lot of the content for these sessions in particular.
Tackling the procrastinating trainee was fantastic, and you can
Yeah.
learn a lot about yourself in these sessions as well. So there are some quite offbeat but really, really helpful topics at that conference. And I was just going to give a shout out. Whilst we've been away, we have dropped a few pre-recorded videos. So
Yeah.
there was a video about understanding the GP patient survey. That's
Mhm.
something that we all need to look at every year, and something that we need to talk about amongst our practice teams. So, but making actual sense and actual use and
Mhm.
understanding the statistical power, for example, and some of the issues behind the GP survey is handled there. Gandhi's been away doing something interesting. I don't know. Is that something you would talk about here, Gandhi? You've
Yeah,
been
so I've been off running a healthcare aspect for a religious event, which covered about 15,000 people for the past week or so, trying to support the community with checking their blood pressure. So I've created a video that's specifically in our language and stuff. But actually, the English version of that is coming out next week, so you'll see that. So hopefully, a handy video for practice to share with patients of how to check your blood pressure. It is literally like 50 seconds long, so it's awesome from that point of view.
fantastic,
And we
and
also covered
it's still hot. Gandhi's got
yeah.
a video about some common heat wave issues. It's still hot. It's going to be hot for the rest of the week. So check that out. And then we're all dealing with change all the time. So there was an interesting video about managing change, looking at some common change tools that you can use as you engage with change yourself, or help your teams through change as well. So check out some of the content that's been around whilst we've had a break and a hiatus from the live content that we've been doing.
And
So
if you
great.
haven't done, do subscribe. We are not far off hitting our 10,000 subscriber on YouTube. We will probably hit that in the next couple of weeks or so. So if you want to be that 10,000th subscriber, we need to do something fun for it, don't we, Andy, when we hit that?
I was going to ask you, what are you going to do when we
I
reach
don't know.
10,000? Are we going to?
We had our 9,001 video that we did, which was just a bit of fun and stuff. But yeah, I think I've got some ideas. We'll
Okay,
have a
we'll
look
come
at
up with something. We'll do something interesting and show you on a video.
Absolutely. So everyone, as ever, if you do have any comments or questions, let us know. We'd love to hear from all of our viewers and stuff. Christina, thank you. She mentioned she's booked already onto one of our conferences. Don't know which one, but hey, it's awesome that you'll be joining us for that, and definitely share it with your colleagues and stuff as well, because these conferences are unique. We run the System One Facebook user group one, so we can guarantee you there's nothing similar to that elsewhere. And in terms of GP trainers and stuff, again, we think it's definitely unique and interesting because the content we provide is not seen in other. I attend a lot of trainers events and stuff, and I know for a fact no one else does this kind of stuff and things. So definitely sign up and stuff. And as ever, EGP Learning is here to help tech enhance your primary care and learning. And we'll catch you in the next episode. See you later.